I'd like to start with what's a true story, but a story that I've not witnessed firsthand. I've heard, from a student who's incidentally here. So it is true, and she can, attest to that. In their juniors' first year class, she was telling me this. Students from different parts of the country were just settling in, young, bright minds full of curiosity and new beginnings. One afternoon, a loud thud echoed in our university. It's a small setup at Vidyaship. And in a heartbeat, three students, all from a conflict affected zone, now we know, dropped to the ground, ducked beneath their desks, holding, their hands over their head, elbows tucked in, as if trying to brace for impact. The entire class froze, not knowing what to do, what had just happened. And it turned out to be a regular, I think all of us Bangalore people are used to the, regular thud noises from, one of those flights and construction noises. It turned out to be that. But that instant, it revealed something profound. That the body remembers what the world might forget. How fear and vigilance can live quietly beneath the surface and travel with people into their classrooms, into workplaces, into daily life. I'm Sheetal Lakhani, I'm your moderator, and my role is to bridge between you and the panelists, and please help me do that by staying interactive in the Q&A when we open it up to you. Dr. Kim Nehat, I can say, is an authority in the field of women's mental health, really. And she's recently received an ICSSR, which is the Indian Council of Social Science Research grant, to work on the Manipur conflict that is ongoing. It's especially focused on women and women's mental health in that zone. Really looking forward to hear from her. Dr. Dinakaran is an expert in disaster mental health, it's not a very common area to specialize in psychiatry. So I'm very, very glad that he's here with us. He's from the Department of Psychosocial Support in Disaster Management at NIMHANS, which specializes in the theme that we are here to discuss today. Dr. Abhishek is very passionate about his community mental health work, along with his training in political psychology, which brings a totally different lens from the clinical lens that we take. So I'm hoping that this multidisciplinary spread that we have, we're able to make use of that for a great conversation. 1 in 5 people in some disasters, maybe 1 in 3 or even 1 in 2 people end up suffering from mental health issues, and we'll talk about that as we go about this experience, this panel discussion. And mental health often comes as an afterthought, as it does even in non-disaster situations. That's why we call it a silent crisis, this discussion today. And at some point, most of us have already or will face a crisis or a disaster situation. This is why WHO, the World Health Organization, decided to keep the theme of this year as access to services in times of emergency. The World Health Mental Day, for those of you who don't know, is celebrated on the 10th of October, and it's in that honor that we are here today to respect this theme that the WHO has brought out. May I now invite Dr. Dinakaran, our first speaker, to give his opening remarks. Please welcome him with an applause.
Good evening, everyone. So thanks, Dr. Sheetal. Thanks for this wonderful audience in a Tuesday evening. So she was referring to that we might have had some experience with disasters, or in future we are going to encounter something, but we have gone through COVID. There is no other huge disaster that has happened, at least since tsunami 2004. COVID has been a huge pandemic. So that we have all gone through, or otherwise the virus went through all of us. So we have all faced disasters. And in that context, let us examine what do we call as a disaster first, right? Because it is common lingo nowadays to throw away trauma or disaster in a very casual sense. Say, for example, you went to a movie. Somebody is asking you a review about a movie that you just watched. The simplest feedback is, oh, it was a disaster, right? And or how did your exam go? Oh, it was a disaster, don't ask me. Worse, how is your relationship with your boyfriend or a girl? That's a disaster. So we use it in a very casual sense, but to this talk, for this presentation, let us define it in a serious way. So what is called as a disaster is, see, we have to understand the difference between what is a hazard, what is a disaster. Hazard is any natural or a human made event. Hazard can be specifically a cyclone. Cyclone is an hazard, right? Earthquake, volcanic eruption. These are natural hazards. And there are certain human induced hazards like radiologic fallout, war, terrorism. These are human induced hazards. When do they become a disaster? That is what we have to understand. Hazard existing doesn't mean that it is a disaster, because on a day-to-day basis, Himalayan mountain ranges see a lot of landslides. They do not themselves constitute a disaster, because the disaster as it is defined should overwhelm the coping capacity of the suffering community. Say for example, cyclone that is not going to have a, or having a landfall in a remote island where there is no human being or not much other organisms or animals, and their coping capacity is not exceeded, cannot be called a disaster. Landslide that has not affected much of the flora or fauna cannot be called a disaster. What is a disaster is when the hazard happens in a particular region and it overwhelms the capacity of that region. Say for example, a flood happening in Chennai overwhelms the capacity of Chennai to overcome the flood themselves. So they need support of nearby states and cities to go and help them during the time of crisis. That is called a disaster. So intuitively, if you want to understand, if we have better capacity to manage all these hazardous events, say we are very prepared to face flood, very much having capacity to manage earthquakes, we can prevent disaster. So that is what I want the audience to reflect on. So this is the disaster management cycle. The red one is the disaster. Yellow one is after the disaster, there is a response and a recovery phase. Green is before disaster, what are the things that we can do, preempt, to prevent or reduce. Mitigate is nothing but we know the event is going to happen, but how can we reduce the impact by taking away people from their vulnerable places and keeping them in a secure place? Can we mitigate the impact of the disaster? So you can take a guess where the government, you want the government to spend more, either in the green part of the cycle or in the yellow part of the cycle. Unfortunately, not just India, across the globe, most governments spend in the post-disaster response. They do not spend much in developing the capacity, which we can take up during the discussion. So what happens because of disaster? This is not individuals. This is about what the community goes through. So the graph, when you see the graph, you have to think about what the community is going through, not one affected individual in the disaster is going through. So pre-disaster, there is a psychosocial vulnerability. During the impact, there is definitely a dip in the mental health of the community. And then there is a phase called as the heroic phase, where people come together despite knowing that trouble is going on. The natural empathy of individual social support comes outward immediately, and it lasts only for a few hours, maybe 24 to 48 hours, when despite being in flood, they want to help other people who are suffering in flood, or it may be any other calamity for that matter. And then follows a honeymoon phase. This is when Chennai is suffering with flood, there is so much supply being sent to Chennai. There will be hundreds of trucks with the food, relief materials, sanitary napkins, medicines. They are overloaded with the inventory. They feel as if they are in honeymoon, though they are just recovering from a disaster. And again, it is very short lasting, maybe for 2-3 days. Once the inventory starts to come down, people go into this phase called disillusionment, which lasts from a week till it can go till 2 to 3 years for the community that is affected to come back to the so-called normalcy. With or without intervention, please understand, all the communities that have faced disaster will always come back to their pre-morbid or pre-disaster level of functioning, but there will be lot of setbacks during anniversary events, and it depends on what support people get. And as you see, there is not much support in any disaster for that matter. People go in, maybe a Wayanad recent landslide, people go in, they support only for a week or 10 days, and then they all go out. It is left to the people in the community to go through the event for the rest of their life, and that is where the recovery and rehabilitation phases are not fully understood by any of the researchers yet. And this is true only for natural hazard related disaster. Don't think it will be the same for war and terrorism, because in human induced disasters like war, terrorism, Manipur conflict, or there is a nuclear fallout, what happens is the white line. There is no heroic phase. Like COVID, nobody will go and help the other person. They will simply want to run away from the disaster. No heroic phase, no honeymoon phase, only disillusionment, and we are less forgiving. For a natural event, we give different reasons for the natural event. We tell maybe it is God's will, and then we are not blaming other human being for a natural disaster. But for a human induced disaster, there is a lot of anger. It is because of somebody's mistake this has happened. So that anger will not allow for healing, and it will take a prolonged course. That is what we have seen from Bhopal gas tragedy. We have 4 decades of experience with Bhopal gas tragedy, which says that people are yet to come back to their old self. So what can happen? These are last 2 of my slides. What can happen in a mental health of the community following a disaster is, people need support. Everybody needs support during the acute crisis. Maybe for the first 2 weeks, for the first 1 month, everybody needs support. Doesn't mean that all of them are mentally ill, because whatever reactions that they are going through because of the disaster, it can be fear, anger, depression, anxiety, all these are normal reactions because they are put in an abnormal situation which they did not expect. So you expect the normal reaction to come during the acute time, and people will have their own coping capacity to overcome this problem and come out on their own. So, but they all need support because it is an extreme event. So mental health impact can be acute, which can be anxiety, depression, or prolonged, say in the name of PTSD or substance use, because these are the common problems. What is also important to understand is, disasters are not going to just impact the mental health of the individual. It is going to impact their physical health, physical infrastructure, social unity among the affected population, economic stability of the region, because no more, if a region is prone for earthquake and landslides, nobody is going to come and invest there. It is going to take away the jobs. And then it may have legal implications with respect to child trafficking, child marriage, more domestic violence, and women trafficking, which are common in a post-disaster situation. All this can have an effect on mental health of the affected community, as well as the mental health, if it is affected, will not help people to heal in a better way. So we have to understand the bi-directional nature of this. With that, I end my opening remarks. We'll take questions as it progresses. Thank you, everyone.
Thanks so much for the crisp and on-point presentation, sir. I now call Dr. Abhishek Kumar for his opening remarks.
So I'm very honored to be part of this panel, where we are trying to, through these questions, it invites us to think about what it means to care for communities, and when everything is falling apart, when there is uncertainty all around. Um, I would mostly reflect on my experiences of working with women's mental health in Garhwal regions of Uttarakhand. And through my presentation, I'm trying to do 3 things. First, I'm trying to see how crisis exposes pre-existing inequalities in the order. And then through my fieldwork experiences, I'm trying to also see how disaster-prone areas reveals gendered suffering. And finally, the main crux of my presentation is, how do we build ecologies of care for preparedness within the community? How do people from within the community come together and be prepared for anything that goes wrong? So to start with, what does a crisis mean at the first place? It, of course, includes conflict, disaster, displacement, etc. But the crisis that we usually talk about is what is visibly lost, what we can see in front of our eyes. That is, roads, schools, hospitals being broken down into. But within those collapsed buildings lies disrupted lives, whose sense of safety, belongingness, continuity is suddenly shattered. In such contexts, mental health support cannot be treated as optional, but it is necessary for any reconstruction to be imagined. What does a crisis again do? A crisis does not only create and talk about suffering, but it exposes the fault lines of inequality that is there within our society. It shows us who is protected, what groups are protected, and who is left behind at the end of the day. The likelihood of experiencing trauma and capacity to recover from it is, of course, shaped by the position of social hierarchies that is there in our society, be it gender, caste, class, or even geography for that matter. For example, studies suggest that disasters, even in disasters, women, children, and marginalized communities are disproportionately affected. But the question then is how to improve access to care, how to repair systems of inequality. And one such way to imagine this is the capacity building at a community level. This is what I'm trying to do with my research with Garhwal Hills. It is one of the most disaster prone areas where cloudbursts, landslides are a common occurrence. But within this crisis, what is more devastating is the everyday geography of hardships that these people have to face. Most villages only have single or one primary health care in the entire block, very poor connectivity of roads, lack of health awareness, etc., and even improper dissemination of government schemes that are there, which together adds to the cycle of vulnerability in the hills. We did a baseline survey with 558 women across 18 villages and 9 gram panchayats, and we were able to find that 70% of them were unaware about mental health. More than 58% felt stressed. The common causes of stress were migration, where their male counterparts, male partners, or young children are out there too, and then they are lonely in the entire family, entire village, and that also disproportionately brings their caregiving burden on them. And then in occurrences of, for example, disaster, a financial loss is something that is burdened on the women. Again, this is also reflected in the support services. If we see, even if there is such high level of distress, 58% of women, awareness of support services were almost absent. Nobody was aware that they could even reach out to someone in distress. It was very low. 64% of them said that they would be interested in assessing mental health services if it was made available to them at the very first place. This statistics tells two things. One, that the distress is widespread, more than what we imagine. And second, the willingness to seek help again exists, but the ecosystem of help is not there. In our interviews, again, women described exhaustion not as mental illness, but a normal part of life. They don't have a vocabulary of mental illness, the kind of vocabulary that we have. But that is seen as a normal part of their everyday life. They carried emotional and physical burdens silently, manifesting in somatic symptoms like body pain, headaches, sleeplessness, etc., which also reflects the gendered labor and social invisibility, which acts as a vicious spiral in our society, and particularly in this community. Before we try and design for solutions to these problems, we also need to confront the barriers that exist. And the barriers are again mostly two types, one structural and the other is cultural. The structural barriers is again physical remoteness, like I talked about. Then there is again opportunity cost. The opportunity cost being that if I have to access some mental health services, I have to walk down the road for like more than 2 hours just to come on the main road and then access that one public health center. I would have to give up my 3 days of wage to be only able to access that service at the first place. So that opportunity cost, again, that is also reflective in the scarcity of health services that is there. Second, again, is cultural. We all know how stigmatized a mental health issue is in our society, and more so here where people do not have a vocabulary at the first place. They don't know what mental health, mental illness is. And then there are gender-based norms where women are expected to be resilient, self-sacrificing, and emotionally composed at all times. We don't have an imagination of a woman which is not functional, so to say. They have to work. There is no other way, right? Um so how do we then move forward? How do we create models of care that are not only accessible but is also owned by the community? This is where we build ecologies of care. What we need is a participatory based action research where we need to know what the problems rise from the field. What kind of services do they need? What are their problems? So, what we are trying to do, there are some initiatives for preparedness before a disaster comes or any occurrence of this nature comes. So, we are trying to train local women as Swasth Sakis, which act as community health leaders, and again form Mahila Swasth Samoos, which are women's health group, with the idea to co-create spaces for shared reflection, collective coping, and mutual support that they can give to each other. From one of these efforts, we were also able to come up with some powerful initiatives right from the field, which the women participants themselves came up with. One was a Sukoon Manch, which is a place where they meet every 2 weeks to share stories, regain sense of control over their emotional lives, where they don't have anybody to reach out to, talk to. And the second one is Wellness Garden Project, which mostly looks like a nutritional project to most of us, but the gardening gives a communal, mindful, and nurturing activity, which is a space for connection and meaning making for people to come around. And this is all coming from the field. This is nothing that we came up, that let's come up with an idea of wellness garden. This is what they wanted, and we are able to come up with a project like this. These initiatives, what are these initiatives also underscoring is that we need ecology of care at the end of the day. And this can only be achieved when we are able to liaison with NGOs, gram panchayats, and other mental health professionals in a non-hierarchical way, a non-hierarchical fashion, where we learn from each other. We talk about mental health issues at the grassroots level. And through this, we are also trying to move from the rescue and the relief model, which is very much prominent, to the recognition and the transformation model. And there are also some government initiatives like Telemanas, which we are trying to incorporate in the field, but we can talk about some problems that are there, which I already discussed with Dinakaran sir. These are some training that we are trying to do with the Swasth Sakis in the field, where they can again go back to the field and then talk about health issues. And then this is the training on Sukoon Manch, and then liaising with the Gram Panchayats, etc. Yeah, that is me. That is all about me, and we can take up present questions later. Yeah, thank you so much.
Thank you, Abhishek, for bringing a very different perspective from the clinical perspective that we have heard of. I mean, may I now invite Dr. Kim Nehat to share her.
A very good evening to everyone present here today. So, Dr. Dinakaran and Dr. Kumar, they have already talked about what conflict, what disaster is. Today, I'm going to share about my experience, a lived experience of the conflict that has happened in Manipur in the year 2023. I think many of you would be aware of that, and which is still ongoing till that. So my experiences to that and the work that we have carried out in some places of Manipur. So it's more on my experience sharing. So as you know, Manipur is in one of the northeast, eastern part of India. And in Manipur, we have an ethnic diversity and tension which is going for many, many decades. You know, it's a home to a majoritarian Métis community. And then we have a tribe called Kukis and Nagas. So, and then different smaller tribes that we have. So we keep having after every 5 years, you know, there would be some ethnic classes between the Métis Hindu, Métis Kuki, or between Kuki and Naga. So that has been ongoing, you know, but then it won't last long. You know, it will be for few months and then things de-escalate by its own, and we coexisted peacefully again, though we have some reservation towards each other. So on May 3rd, a conflict broke out, erupted between a Kuki Zo community, which is a tribal group, and then the Mesoritarian Meitei communities. The conflict stemmed from a protest against a court order that the Meitei, the general, were given an ST quota, which the tribal feels that, it's not right, So this was the reason why they have a rally, but then uneventfully there was a conflict which broke out, which has led to a widespread devastation. Houses and villages were burned, religious institutions were burned down and destroyed, and now to the extent that communities are fractured into ethnic lines, so now be from one of the community cannot enter the other community territory, to that extent it has come up to it. And because of the conflict, we have more than 200 deaths, thousands of injuries, and displacement of more than 60,000 individuals. In some of the records, they said it's more than 70,000. Okay, so what happened was that just talking about my experience, I was there. It was a vacation given by NIMHANS, a summer vacation. I was home. And it was on 3rd May, I was happily home because it was a vacation closing, towards the closing of my vacation. Then on 3rd night, my neighborhood, people start burning the neighborhood, and we didn't sleep the whole night. We put off the lights, closed the gates, closed the door, and then luckily we have a CCTV. Some of the neighbors' family came to my house because my house was a bigger house than them. So the whole night we were quite vigilant of what is happening, who is passing by our locality. And then around 3 a.m., 4 a.m., then a group of army came down for patrolling. That's when we feel that, it's safer. Let's sleep for a while. And that's when we sleep. But around 7:38, a neighbor called, and unfortunately, my house was in the first lane. My house was the beginning of our community, my locality. So then one of my neighbor called up telling that you have to run for your life. A mob is approaching towards your house. So that was the message given, and they called my mom, and that is when we have to just rush. We don't know where to go. And for us at that point of time, we called several police helpline, everywhere, but no response on that day. I think everywhere in Fall City, there were an escalation, and police were helpless in that situation. So then we rushed to the nearby army camp, thinking that we would be the first one to reach there. By the time we reached, there were already thousands of people inside the camp. Then I think by 12 noon, the camp was it was a CRPF camp. It was not very big, but we were more than 4,000 people cramped inside the CRPF camp. People were quite, they were quite helpful, supportive. They gave us protection, but they were failed to, handle so many people unexpectedly. So there were no privacy. We were all in the ground, cramped inside that building, and all those happened. So then luckily my ticket was, I have already taken a ticket for the 6th, because 7th I have to join NIMHANS back. Then on the 6th, my flight was at 2:30 a.m. Then we have to request the CRPF people to drop us to the airport. Then by 4 a.m., they woke us up and told us, you go prepare now, let's go there to the airport, because later on it's not going to be safe. So that's how we landed at the airport early morning. And this is the first time being from the Northeast. I think many of you would be aware of our culture. We love fermented food, we love bamboo shoots, which are not available much here. So we used to carry a lot of home food and then come here. But that day there was nothing. Luckily I grabbed my laptop, so that with laptop I've reached Bangalore. So that's how things were. So what happened when coming here down, I was very surprised to see that in the national media, in the local media, nothing was coming up. When I started speaking to my colleagues, they said they were scrolling up the news. Like, you have suffered so much, but nothing is coming up. Until people get to know, until when, I think many of you will be knowing about this, that two women were paraded naked. I think that's when the whole nation, the whole world came to know about this, and then that people get to know that there is a conflict, and then and in that conflict, women bear the brunt of it. So these are some of the things. So working with the women or the community, women in any kind of disaster, even in the recent COVID that we have, the violence, domestic violence escalated. Even in Manipur conflict, the same happened. Women were used as a weapon of this conflict, raped, murdered, burned, so all women being assaulted. So these were there. So apart from the socio-economic hardship, because most of them lost their home, their livelihood, apart from that, they lost, there is a loss of agency in women. And then the trauma that they have to go through, and lots of gender-based discrimination that has happened. So some of the work that I have work on, before I go to that, I think this has taken a toll on the mental health of the community. Many displaced populations are there where they are now living in a deplorable living condition with high mental health, affecting their mental health. Okay, and even till that, there are many people who are stranded in the relief camps, till date. So, and there is a lack of access to structured and culturally appropriate, because there the culture is very, very different. And mental health services, we have a very, very less mental health professionals in Manipur. So these are some of the challenges that we have it. So this is one of the study which is done by one of my MPhil student, just to understand that the people who have come out from Manipur, and how do we come about. It was not of choice that I want to go to Bangalore, I want to go to Delhi, I want to go to Guwahati. On that few days, the internet were run down, and it was shut down for many months in Manipur. Then the family who were there in Delhi, some of the relatives, just to save the family, they've taken the tickets without any plan where they are going to stay, how they are going to live. It's just that you just wanted to escape from that conflict zone. So that was the thing. So many, all of them have come to Bangalore too. So when we did a study with this population, and talk to them, like what happened to them, what is going on during that phases. Then they said that during the crisis, the immediate shelter that they have taken were in the army camps mostly. And some of them talk about, like, they just run to the jungle area, forest area, and they were the communities, 5 to 6 villages, they will lived in the jungle for 2-3 days until the rescue came in, and then they were taken into the protected areas. So these were how, this is some of the screenshot from the camp that we have gone in. And about the loss, many of them talk about their house being burned down. They have lost the house, and until then, those who are living in Imphal and the vicinity of Imphal, we still can't go back. We have lost everything. So loss of livelihood, injury to self, they were also being beaten up, injury to family members, and death of family members were some of the things that they have reported. And then access, we also want to know about whether they have an access to healthcare in Bangalore. So many of them said that they have experienced a health issues, in one or two areas, more than one or two areas. So in physical, it was a little lesser, but in mental health, I was very surprised to see that, they could identify that they have a mental health issues, and 60% of them said that, I'm going through trauma, I'm going through depression, I'm very anxious. So that's how they talk about themselves. And pregnancy related issues, complication during their pregnancy, because some of them said, we are in an army camp, I couldn't go for a checkup, and then there were lots of complications during that time, and malnutrition. So many of the family who have landed here in Bangalore, they said, like, first we have to feed the children, and then only the leftover is what I get to eat. So these are some of the, and then we asked her, if you have experienced this, then have you gone and consult someone? Then I think 51% of them said no consultation, and some of them visited doctor on regular basis, and mostly on their physical health, and two of them are on therapy. So this is the thing. And the psychological distress was very, very high, like 84% of them. The score was 84%. And this is where I want to focus on the perceived social support. The result says that about 78% say that it's the family who give them a whole lot of support. Then about 67 said significant others. So when we discuss with them about these significant others, they all talk about the community support. We were supported by people whom we don't even know. They give us shelter, they give us food, they give us, some clothes, because many of them came out without a pair of clothes. So that has really helped them, and that has kept them going on. That's something which I really want to emphasize today. And then some of them get help from the friends. So, and we happen to work with one of the the camps in Tengnopal district, which is a border with Myanmar, Burma. So with women in the relief camp, so one they talk about is that they have lost their livelihood, they are worried, concerned about their children's education, their career, their future. And nutrition is something which they talk a lot about, because there is deficiencies during pregnancy and after, when they are lactating mothers. So that's something that they talk about it. And these women are in the relief camp still. And medical needs. So mostly that part of the district, whenever they have any health issues, they have a small PHC, but most of the medical thing, they go to Imphal Valley. So that has been shut down. So they don't have any medical help, So, and some of the narrative that while we talk about them, what they say was that all life and memories of loss hope make one feel depressed. I lost interest in building a house again, feel emotionally drained, and see no point in starting over. Even the concept of rebuilding the house itself was still traumatizing for them. So these are some of the narratives. They have lots of problems, access to water, no privacy, and then the memories, the flashbacks, it keeps coming with them. And then the way they lived in the relief camp, with different families whom they have not known, so there are lots of conflicts happening there itself within them, because of the children fighting, or because of some family loves to keep the things clean, but the others are messy. So those kind of things were ongoing. So, and they feel that even the other communities who were not involved in the conflict, they feel that they are being secluded. When we go to buy rice in the nearby bazaar, people, they say that we don't sell food grains to your community. That's how they react, So, and that was quite painful for them. So these are some of the things. I think we will take up the questions later on. Yeah, thank you so much.
I think there was a very interesting, diverse, discussion on disasters. And I'm going to try and bring it together by actually first asking about. So I'm going to go straight to budgets because I'm a Gujarati and I'll stay true to that. Why are governments not spending enough on the green zone, as you said, in preparing and mitigating for disasters, as opposed to response and recovery?
So there are different frameworks that say how much you may have to spend in a particular phase of a disaster, so that the benefit of it will translate more than what you have spent. So there is a recent framework that we are all following, is called as a Sendai framework, that has come in 2015, and it has a plan till 2030. What is suggested in Sendai framework is 80% of the allocated budget should go to pre-disaster planning and capacity development, and 20% should be reserved for, even if there is, after doing 80% of the work, if there is some disaster of huge magnitude and severity that happens, people can use that 20% of the fund to help people to recover their losses. This is the ideal scenario. But what happens in any country, at least from our country perspective, is we spend 86% of the allocated budget for disaster management in the post disaster response, recovery and rehabilitation. Again, the most is spent for the acute crisis and the acute response. Maybe 5 to 10% of the budget we spend for the pre-disaster phase, because there are a lot of philosophies. We have to change the overall philosophy. Always disaster management has been seen as the post-event performance or post-event work. The philosophy of getting, so even the philosophy about earthquake was build back better. So when there is a crash after an earthquake, the philosophy was, now it has happened, while we are building this again, let us build it back in a better way so that it will withstand earthquakes in future. So that was the learning, at least till 2015. The philosophy has changed now, build better before. So that change of mind has come only in paper. For people in politics, administration, to imbibe this principle, this new philosophy, that it is very common, right? You all have at least a notion of insurance. There is something called as a life insurance. There is something called as, you all drive vehicles, vehicle insurance, and then medical insurance. This is a very core concept that we prepare better when there is an untoward event that may happen. So why would a government that is forcing the citizens to prepare better will not itself prepare better, is the question right now the entire world politics is facing. So for that behavioral change to happen, now we all are thinking, okay, we have to spend more in the pre-disaster phase, but to implement it, people are lacking vision about how to implement it. How can I spend? Where should I spend? How much should I spend in physical infrastructure? How much should I spend in resilient schools? How much should I spend in resilient job market? How much should I spend in resilient hospital market? So this is what has not translated from paper to action, and that is where we lack. We still are spending, even with the 23 budget review, we are spending most in the post disaster response and recovery, rather than spending so much before disaster, so that we have resilient physical structure as well as resilient human resource. It's not just the physical structure. No? The people who are living in the community also should feel resilient about. When will that resilience come? Only when they feel very safe about their neighborhood, that they are aware about what are the different challenges that neighborhood may have in future, and how they can better prepare themselves to face these challenges. That has not gone at all. We are still in that knee-jerk reaction mode. Some bad thing happen, immediately you will have 100 committees auditing why it has happened, how to prevent it, but we don't preemptively do plan and have a vision about how to overcome.
So, and I'm very, very aware that while you say that you're already working yourself, you and your team, on preparedness, there's a, I've gone through your papers, for example, where you're surveying primary health physicians, because that's also where a lot of the community ends up going, whether they are aware of and are trained in disaster mental health. And I was surprised to find in your study that they are not. Are there any such steps that need to be taken in your view to enhance this?
So thanks to bringing that study here, because what I work is in a health field. What I can see is whether I can develop a health system that will work in any disaster. Be it pandemic, be it a nuclear fallout, be it a war, whether my health system can work. So for that, we need to see whether the doctors who are there, because in a disaster zone, not Nimans can take me in a helicopter and drop me in a disaster zone. That is not possible because there are a lot of logistical problems. So the first responders are the primary healthcare doctors, the doctors in the nearby hospital, doctors in the nearby district. So we wanted to conduct a survey and see what is their knowledge, what is their attitude, how are they practicing this disaster mental health related response. So what we found out was their knowledge was wonderful, their attitude was very positive, but practically they don't have the skills. So when you say KAP, knowledge is really good because it's theoretical knowledge. Attitude is good because they really wish to help people in the times of crisis and disaster. But practically, how to implement this? What should I ask? I know I can measure temperature, I can measure BP, I can measure respiratory rate and say that you are physically well. I can give a physical first aid and give you stop your bleeding or reduce. I can give painkillers to reduce your pain. I don't know how to take care of your mental health pain. So for that, we have devised a specific program, an online certificate program for all these primary care doctors across the country, because we know now what is lacking. So the lacking is the practical skills. So we are focusing only on this practical skills for 12 weeks. Every week, 1 hour, they can spend their spare time on a Friday afternoon. 1 hour, they will come online. They will learn through different case scenarios that are real from our experience over the last 4 decades of working in disaster management area on how to assess individuals with mental health problems, how to ask question, what are the basic questions one should ask, what are the high risk questions one should be aware of while asking, how to provide basic first line psychosocial support, how to provide calming exercises, not about pills, how to give a helping hand, how to teach them sleep hygiene. What is sleep hygiene? How important is maintaining a routine post disaster? Just because disaster happened doesn't mean that you have to lie in the camp throughout 24 hours. Then you will not sleep. So how can we make their routine soon? By making the routine soon, most of the mental health problems can be taken care. This is what we all do, isn't it? We all have an immediate crisis in our family, say a loss of loved one. How do we normalize? So we know that we go through the grief. Every culture has a 10-day, 12-day ritual, 13th day program, 16th day program. They come together, and then after 16 days, there is a routine that sets in the family, the new family, even if they lost their head. Children start going to school, breadwinners start going to their work, they grieve, they continue to grieve, but there is a routine that is setting up which kind of protects them from the worse mental health long-term impact of the loss that they have faced. Similar model we are trying to apply in the community, but it is a work in progress. You know, India is a vast country. There are so many doctors, at least 750 plus districts. To cover every one of them, we are trying, but it is a work in progress.
Absolutely. Thanks so much, sir, for bringing that up. And Dr. Kim Nihat, I wanted to ask you. I'm also, as Dr. Dinakaran was speaking, I was also thinking of how much of a work in progress it is. Because the questions that you raised about how to even intervene in disasters and in crisis is an unanswered one, even in mental health professionals to a certain extent. So I know just a few years ago, we used to do trauma debriefing, which is that we used to sit down with individuals post disasters. Trauma counselors would go on site, although not so much in India as much as America, where a lot of our literature comes from. And they would speak to the individuals who have gone through a disaster and ask them to share what they're feeling and relive some of those narratives in the hope that that would prevent PTSD, which we learned later was a total mistake. Trauma debriefing doesn't help post disasters. And then came in the last few years psychological first aid. So as I understand, we are also developing and learning these methods. What's your take on how can we take this forward, ma'am?
Okay, for this, I think I'll go back because I have recently experienced with the Manipur conflict. So let me go back to that again. And because all the conflicts, war or disaster, they have the similarity. That's the loss of life, the loss of your livelihood or your health or your peace. So all those. So, what works with the community this time? What them, the displaced person or the one who were affected, what they say was the community support, and in that community, mind you, there were no mental health professionals. They were all religious leaders, they were the community leaders, they were the women group, who when they went into a safer district, they were with no belongings, so they give them a space to stay. The people bringing food, like, the honeymoon period, like everything came in for them. But what works, what the women or the family talk to me about was that the community came to us, they will worship with us, they will talk with us. Then there in Manipur, in some of the tribe, we have a traditional singing together, we call it lenghom, so they come, sing together, and we share our problem. And just them coming, one old man, women will come in and check how you are doing, how things are. So that itself is like, you feel really good that you are still wanted. There are people who cared about you, though their people are trying to kill you, they were after you, they have taken away all your property. But when you came to this place, you feel that, okay, you are alive again. There are people who are not that type. This people are more the caring people, so those kind of community work helps. And then the liaison between different sectors in the community, like the health group or the police, or when they have a smoother communication, and all those things works better for the conflicted individuals is what I feel.
That's wonderful. You're in a unique position, ma'am, to have both your lived experience and your expertise, and to bring that together. We are really, really, very glad to have your perspective here. I'm also wondering if you could tell us a little bit more about your upcoming ICSSR study and what you hope to achieve with that, and how you're planning to take that work forward in the Manipur.
So this is the offshoot of what I have just presented in displaced person who are in different cities, who have come to different cities. So mostly women again in the reproductive age, because this time in Manipur conflict, as I've seen you, women, were used as a weapon. And then in many of the interviews that we have with the survivors, so they talk about that, and those videos and those kind of news had really took a toll on them, for the women. So that safety issues, trust issues, all those things comes up. So what we thought was that this project is about looking at the mental health aspects, looking at the gender-based violence, if there are in the community post conflict, and then looking at how resilient they are, the strength perspective, so that, when we develop a module for that, we can use those, things. So this is about this. So it will take place in Delhi, Bangalore, then in the northeast part, Guwahati, then in Shillong, so that's about the 4 city study. So we also have one more, that's not a part of ICSSR, but we are also now planning with the Tingnopal group, which I said for the displaced women. So we are also making a module based on what they need, the need assessment for children specific, and then for community. But we wanted to specify it for women because women needs are different. And we also specifically wanted to do it for the men, because men are less likely to express about their mental health issues, because they have that responsibility of taking care of their family. So their mental health or their well-being comes behind. So that's a model for them and for the community, so that they are quite sensitive and sensible in handling those people who are, victims of the conflict. Yeah. So.
It's wonderful. Thanks for sharing that, and we look forward to that work and what it brings. Um, Abhishek, I'm curious. You brought up your community work in the Garhwal, which is quite a disaster-prone area. I'm curious if you have a case or an instance or a research finding, perhaps, that stayed with you, that you could share with us, and perhaps that's true for all the panelists. This question, if you'd like, please jump in and.
Yeah, before I like move to that, I was like very curiously talking about like listening to you about the trauma debriefing and the psychological first aid and what Dr. Kimni had talked about community support. I would just want to briefly flag about the kind of when you think about mental health and issues in the community, one thing that constantly comes to our mind is professional help, professional intervention. But the question again is, everyone enters after the crisis. Who is before the crisis? Who is there before the crisis? The community is there before the crisis. What we need actually is a localized care infrastructure. What we are trying to develop in my project is a localized care infrastructure where the women from the community are trained to be able to tackle the problems when the community is hit before we parachute some professional aid. So that is one thing that I wanted to flag off very briefly. And we need to create a a care of trust and familiarity, along with a culture of connection within the community, so that if anything goes haywire, we have each other's back to like fall onto, and we trust each other for falling back onto when there is a crisis. Yes, and yeah, coming back to your question, then there are again a lot of stories of resilience, stories of pain. But when we are talking about the community, what we are also missing is the support that is given from, for example, a public health. A doctor, for example, a psychiatrist who visits there. So I am reminded of a interview that I took with a the first aid. I don't recall what that word is, but who comes and give the first aid, like
Paramedical?
paramedical. Yeah, exactly. So what happened was that they were sharing their experience of the cloud burst that happened, and there was landslide all over, and then the families were all over. They wanted the bodies of all the victims, and they don't know where to get that bodies from. We don't have the bodies, and like the family is there waiting endlessly. We have hands, we have bodies all lying here and there, but how can we join them together? How do they qualify that this is my child, this is my husband, this is my wife? All people, this is a very not that very a picture that is like very close to me, like the way she was expressing all of this, and I was taken aback. We don't really talk about this, and what goes in when we talk about the paramedical, the kind of uh, experiences that they go on a day-to-day basis when they do community kind of work. So that is one story that is very like stayed with me. Yeah.
No, thanks so much for sharing that. And really, you're bringing the community perspective more clearly for us to reflect on. It does remind me of the time that when COVID hit, NIMHANS started its helpline very early. And at that time, I was doing my PhD with NIMHANS, volunteering with the helpline. A pretty scary task, honestly, to do, because I had to keep that phone next to me even when I was sleeping, and my mother could wake up with that call, and all of us traumatized waking up. What I remember is that at that time, the calls I received were about food, like he's saying, other basic questions about where can I find, how can I go home, I'm in the middle of a street, etc. Before food helplines began, the NIMHANS mental health helpline was on. So at some front, there's hope, there's resilience, we are working towards it. The food helplines came in later, and thankfully those calls reduced. But before they did, we put together a list of resources to share with them, because we do need to answer those questions. It is a collective responsibility, as we've been, saying that it is. That brings me to my next question, perhaps to all of you, but Dr. Abhishek, what could we are all sitting here in the audience also wondering, as community, what could neighbors, schools, workplaces, all of us do to prepare, like we said, and mitigate before, it gets to that stage? What can we do?
Sure. I think the very first thing is to recognize that there is a problem. There is, we don't recognize at the first place that there is a problem. And this problem, when I am coming from my community experience, that a mental health issue is very urban in nature. We may not have the vocabulary at the first place, but that is very much out there. So as schools, neighbors, associations, we can create an ecosystem where we are we train the school teachers or all the um, public health like people who are involved with public health to be able to tackle that problem at a community level and before help seeks in comes in. So that is one thing that is on top of my mind, and I think
So, what can we do? Right? Very difficult question. If only we can forecast, predict so many things that can go wrong. Or so, what we can forecast with some credibility is what are the major disasters that can strike your region. You should be aware of that. That is what we are training the doctors for. So, what is the amount of vector-borne diseases? These are also disasters. Like it's not just a pandemic, a virus, or every year there is a particular season. Dengue gets more prevalent. Now rabies is in limelight, right? So these are certain things that are going. So in your zone, in your region, what are the common disasters that can strike and make you feel that it is going to end? That is what we all faced during COVID. The world is going to come to an end, or it is going to be of that nature. So just list it out. Prioritize. Say Bangalore is not in a seismic zone, but can happen. But it's a very remote possibility. Earthquake happening in Bangalore. But what we commonly have is the urban flood. Urban flood is going to be an annual event in Bangalore, and we know there are certain low-lying areas. There are certain regions that are resistant, or they may not have much flooding issue. So in your area, is it a problem? So have a very clear plan of who is your next kith and kin that you are going to contact. Before that, he was referring to the community cohesion. Community cohesion is wonderful, specifically in a natural hazard induced disaster. Our arts cry out a lot and we want to help people. Not so in a human conflict like how it happens in Manipur, it is very less. So how to develop a better community. So within your apartment, how are you participating in the resident association? Are you really participating? If at all, what are the plans that you have for a specific outbreak? If there is a viral outbreak, if there is a problem, what are the plans that you have? At the family level, involve children in this planning. They are more smarter and they know how to convert words to actions than adults. So they are really interested in making this checklist. So one of this mechanism is called as child focused disaster risk reduction, because they are going to be the future. Once it is imbibed in their educational thing, we know that they can anticipate, they can prepare better. So they have come up with very clear, nice guidelines given by the National Institute of Disaster Management on how to develop a family kit for the disaster response. So children will be participating. They know what are the things that they need in a post-disaster event. So they will collect and keep it in a bag. They will frequently check it. Once in 2 months, they will check the expiry of the medicines that has to be stored. They will do all those things. And other thing is, of course, about personal health insurance. I keep repeating the same, but it is the need of the hour. We all should be having that focus. So, this one is interesting case study in cyclone Katrina or Hurricane Katrina. They call it hurricane happening in the Pacific and Atlantic Ocean. So there was a huge impact of houses. Houses were covered for cyclone, hurricane, flood related damage. What happened after the flood was there was electrical circuit loss and many houses got burnt. It was not covered in the insurance. So insurance companies can have their own game on whether they want to compensate or not, but we have to be very careful about what we are insuring, whether we can insure, whether we have such privilege. And finally, as I said, who is your kith and kin? Having 1,000 Facebook followers, Insta followers is not going to help at the time of crisis, isn't it? But at the time of crisis, you always want to connect because you are so emotionally charged. To ground, to feel grounded, you want to talk to the person. Rubbish, you can talk to the person. Nonsense, it can be nonsense, doesn't matter. But you should have that quality relationship, like 4, 5 identified individuals whom you can rely on in the time of crisis. So these are some things that come to.
It's wonderful.
I think they talk about community preparedness and then, about awareness. I think we need to equip ourselves with our understanding about uh, mental health awareness, because whether it's a man-made disaster or natural disasters, it indirectly affects us. So I think this destigmatizing it, and trying to reach out to people, talk about in an open discussion. I think all these can really help person, because even during the COVID pandemic, as you said, we have taken lots of calls. So we have training in different languages and all those. So I was talking about the symptoms of anxiety. Then right after the thing, a lady called me up telling that, thank God, I didn't know that this was a panic attack. I thought I have a cardiac arrest, and I was looking for a way where I have to go to a hospital in this thing. So that's how people are not aware of what it is, how the body responds, how these things are. So I think talking about it in an open space, so that people know where to reach for help when they require it. And all the helplines that we have now, Telemanas has come in, then we have for women violence, we have OSC centers, so I think the educated one can informed are people who are mostly housebound and involved in household chores, does not have the luxury to go out and mix. So all those education among our community would really help in times of crisis, is what I feel.
Thanks to all of you for starting that dialogue here today and for all of you to present for this. May I now open this up to the audience?
Sure. So, good evening, panelists. Thank you so much for the informations. So, I'm Ria, a Vidyashilp student. So, I had a question. Ma'am, I have a question for you. So you were talking about the people who tend to, immigrate or move out for for more safety. So, do you think, for women for families who go through such events, do you think having a support group along with a shelter home for them, maybe for a couple of months till they settle down completely? So, do you think having just having shelter homes for families where food, clothing, everything, all the necessities are given, along with that, a good or a mental health professional as well on board, and community groups would actually help them recover through the experience that they've gone through?
So, are you asking about possible ways of setting up, homes and mitigating or responding to rather?
Yeah,
After
do you
disaster?
think they'll have I mean, do you think that we will be able to, as a community, be able to give them a second chance of life after the events that has happened to them?
I am not sure whether I understand you correctly, but what has happened to many of the cities, like I said, all the internally displaced people. The good thing is that in majority of the cities, we have a very close connected communities. We have a community organizations, and in Bangalore also we have KWS Church, where there is a building. So when people came in, first where they were put was in that community hall, and the nearby places and we are in Northeast, even here in some culture, we are very closely connected. So you might see my surname, Vaipe. So if I see any Vaipe in my community, whether I know him or not, he is like a family to me. So that connectedness, the good thing, the strength about the community is that connectedness is there. So people, when they came running in through train, through flight, so people gather together, they give them a place to stay in that KWS center, and they also actively look for a job for them. what things they can do. Some then they put them into school. Many of them in my study are college going students, and some organizations, NGO, we work along with them. And then the bishops of Bangalore diocese, he was very helpful. He gave lots of accommodation to many of the students, chances, so this is how we work within the community when they came in, because they were left with nothing. So some of them who were willing to work, we look for a work for them, so the community really get engaged. Some now they feel that okay, they have some money, they have earned a bit, and they really need to go back to the villages near to their hometown. So some already have left, but still some still remain doing studying or working here. So this is how we have work. So I hope I answer. I really don't. Yeah, and
So the answer is these initiatives are already in place. Could I take all your questions together if you don't mind? It was all the three of you? Yeah, and then we'll answer them together. Is that okay?
Good evening, panelists. I am Parul, a PhD scholar in economics from Christ University. My question is to all three of you, but mostly driven from the idea presented by Kumar sir. So you talked about how we are enabling communities so that they can support each other within the communities and mitigate the impact of disasters. But when we look at the long term, these areas, even though it is due to man-made reasons or due to geographical or natural reasons, they are prone to disruptions. So how do we ensure the sustainability of these ecologies in the long run?
Thanks for the question.
So, hello panelists, my name is Neha, and yeah, so I'm a research scholar from the domain of health psychology. Yeah, so I was just curious about three questions, and somewhere I'm also closely connected with community and women's mental health. So, my first question is that, per se, when you're giving training or modules to women, there might be still some, stereotypical taboos or maybe cultural beliefs that they might be having. So, how much is the ratio of openness that they are actually engaging in the training? That's one question. And second question is that, per se, when you talk about theoretical frameworks or training, does it have a bi-directional approach? So, like how you spoke about physical, economic. So, I think there's a lot of counseling which is lacking in the bi-directional approach. That is second. And one more question. Forgot. Yeah. So the training which is given, is it purely like theoretical or practically oriented? So these three are my questions.
Thanks a lot. Okay, I was not expecting three there, so we'll just probably take those and come back to you. So on training and on.
So, see, our training is primarily practical training, like what you actually do. Like after checking pulse, BP, can you add an extra question to the individual who is in a camp, just asking, how are you feeling? How is your day looking? So these are not mental health questions, not stigma related. Simply asking them, how are you feeling? How was your sleep last night? It's a very neutral question, right? How are you comfortable in the camp? Are there any difficulties that you are facing in the camp? These are just entry level basic questions that a person can. What is the purpose of these questions? Just to develop an alliance with the person, right? It's very easy. That alliance speaks volume later, because that the person will cherish forever. Because I remember so and so, maybe anybody, a government tahsildar or a school teacher or a primary healthcare worker, anybody who has connected with that person during the time of crisis. You always remember that person, right? That connection is very important. We are saying about social connection, it leads to a lot of neural connection as well. It calms down the anxiety, it makes a person grounded. So that is kind of practical training that we have developed over 12 weeks based on real life case vignettes that we have developed. So simulating the case scenario. And about your next question about whether it is bi-directional, we follow something called as adult learning, which is not me sitting and taking theory questions. No, that is not the way. They bring forward whatever they know already. So I ask them, how do you give mental first aid? Just like physical first aid. They come from an understanding, they give me their understanding, and then we build on it. So it is a bi-directional two-way learning where I learn about your first question, cultural nuances or the participatory approach of the individual. Then it is bi-directional where I try to give my theories and my learnings from the work that I have been doing in a particular hospital. And then it is very practically grounded approach specific to the context of that region. So we take group of medical professionals or nurses from a particular region, so we know that they all share their cultural beliefs, and then we tailor our interventions to that. Because suddenly giving a meat food in a zone where they do not eat meat is not an intervention that we would ideally like. And asking about menstrual hygiene would not be an ideal question immediately as an opening question. But so we train them about practically how to build up entry level question, how to be open ended about these questions, and then finally reach when they are comfortable, when you have formed the connection with the person, ask more in detail about what are the symptoms that they are facing, any anxiety symptoms and things like that. So I hope I have answered three parts of your question. First question was about sustainability.
Just talking about sustainable ecological care in some ways. That's what you're trying to. How do we build sustainable?
These you have already established
Uh-huh.
certain parameters of how you're
What
training
it
these
looks like,
communities
yes.
to help each other within communities. But again, these communities are very prone to disasters.
Yes.
It's a given fact.
Yes.
So due to the disaster, there are high chances of disruptions in the long run. So
Yes.
how do we ensure that the training that we have given within the communities that is sustaining for the long run?
We cannot ensure that the disaster is not coming, right? That cannot be ensured in any way. What we can do is that we can prepare the community to deal with the disaster in the most efficient fashion that we can do in the limited resources that we have. We can have each other's back, we can train local people, but we don't know. Things can change. The way a disaster can change the geography of the area, for example, then we can look for newer ways, newer innovative ways to work. But given the condition that we are, that's how we work. We don't know if this is sustainable or not. We are just starting out. We are just trying things at the moment. Maybe this will not work for like 100 years down the line. We don't know. Oh, yeah, I don't know.
Did you want to add?
Yeah. So about the sustainability, it usually comes from the people themselves.
Comes from the people.
Yeah,
like-
because see, I'll give an example, specific example of Orissa. The one state that is doing very well with respect to disaster management is state of Orissa, because we know every year at least two cyclone there is a landfall in Orissa. We have done a lot of studies on how people adapting to this event, knowing that it is going to happen. You cannot prevent it. Cyclones are going to form in Arabian Sea or Bay of Bengal, and they are going to have a landfall. So this landfall is going to happen in that state because of that geographical curve that it has. It is going to happen. So we have done a lot of lived experience research with these people, and they have given us sustainability solution. So there you don't need to give red alarm. You don't need to telecast so many things. They know because they go to sea regularly. They come from a specific community that depends on fishing. They very specifically know what is the magnitude of cyclone even before you measure it in millimeters and centimeters. They know. So they all arrange themselves into a particular school or camp which are built only for that purpose, and they know after how many days they can go back to their homes also. So similarly in many northeastern states, even in Assam where there is Brahmaputra overflow or the Ganges, so they have built houses in a specific way that 100 cyclones let it come, 100 flood let it come, my house will stay. So that is the sustainability practice. So in our country, which is a subcontinent, every region is prone for different type of disaster, and similar to Japan, how they built their houses resistant to earthquakes, our people have their own indigenous sustainability practices. We first need to learn. We should not go with that I know mental health, I know psychosocial support, I will teach you something. Will not work, because we have to learn from them what they know and see how good that model is and try to replicate in other places, and then introduce what has worked in other places to them. Maybe then there will be a buy-in, and that knowledge will stay for a prolonged generations together.
Sir, I'm Shruti, a PhD scholar in international studies from Christ University. I have two questions that I need to ask. First is the government and institutions, they often instrumentalize the resilience narratives. So, how can psychologists ensure that the mental health interventions are empowering rather than pacifying the affected communities? That's the first question. Second is, how does collective memory of conflictual situations shape the intergenerational memory and influence the community's scope or capacity for reconciliation or resilience for that matter?
Just to intervene, your second question is another panel discussion, but we may still try to answer.
So, with respect to resilience and intergenerational trauma, let me start with intergenerational trauma from a biological perspective. Say, we know like disasters, illnesses are also common in a certain region. Say, for example, African countries, malaria is very common. So common that it has become another individual living in the family, right? How does it change the genetics of the individual? Because that is what is getting passed on to the next generation, right? So malarial parasites are notorious to live in our blood cells. That is how they cause fever and etc. So they want the blood cells to be round to live inside them. So if the blood cells become slightly sickle shaped, so their shape changes, malarial parasites cannot live. So this is the genetic makeup of the individual that has changed in African countries, that has made their blood cell more prone for sickling just for the purpose of avoiding malaria. They did not do anything actively. Because they have suffered so much trauma, there is an evolutionary answer coming within their genetics that make them resilient to future events, right? You can apply the similar concept in different types of trauma, from prolonged alcohol use in a generation, or prolonged domestic violence in a generation, physical abuse, sexual abuse, all this you can say. So that leads on to your first question on how people are resilient and how do we have to approach resilience per se. So in any crisis, any post disaster event, we have 100 people say affected. Not everybody is going to develop mental disorder, right? The numbers have been done, many research across the globe. The number may be immediately 10-20% may develop the disorder as it can be labeled as a disorder. But we know 80% who have gone through, despite having losses, have not developed any mental health problems. And when it goes after a year of the disaster, they all come back to normal. The normalcy picks up, the rates will be only slightly higher than in the general population. What has been wrong in the research till date is we are focusing more on this 10-20 people who are developing mental illness and left the wide population of 80 people who are not developing any mental illness. Because we have that lens, you have to have mental health problem after a trauma, and then when we see through that lens, we pick up only very less number of people and we study what are the factors contributing for them to develop mental disorder, whether it is because of their gender, whether it is because of their education, whether it is because of their socio-economic status, whether they are not resourceful. And resilience research comes from that. Why people did not develop mental disorder, or how did they overcome this mental health problem after 1 year? What made them overcome this problem? But we have left the 80-85% of individuals who did not develop any problem, so they naturally you think they are immune or resilient for that matter, isn't it? That has not been studied to answer that these are the instrumental factors, these are the cultural factors that leads to why a person is being resilient. Only when we do, maybe you all are doing research, go ahead in your career and do such a research, take people who are affected by disaster but have not developed any problem, and then study what are the factors contributing to that resilience. Some studies have come out from the West, and what has been shown is social support. And not just having a social support, how a person is able to access this social support. That's what I was telling. Having 1,000 Facebook friends is not social support. How can you access help from those 1,000 people? How can you reliably depend on certain connections and then access that connection Also, you should also not feel hesitant to access that connection. No, when will you trust that connection? Only when in a crisis, you lose all your inhibitions and go and seek help. So that quality of the individual has come out in a meta-analysis saying that having a social support and having your own ability to utilize that social support is the key factor for resilience. That has been, with the limited research we know, this is what has been shown.